The precision study was an extraordinary highlight today at the EAU. I would say not just today, but for the whole of this year that we're in, this landmark study is going to dominate discussions. It's very welcome. In summary, in the precision study, they took a group of men who were suspected of having prostate cancer, and they were randomized to have the standard diagnostic approach, which is a systematic biopsy, a random biopsy, or instead to have an MRI scan, and depending on whether the scan was normal or abnormal, they either had no biopsy or they had a biopsy of just the abnormal area. And so the key finding in the study was that patients who underwent the MRI pathway with only a biopsy if it was abnormal, compared with those who had a standard biopsy, had a much better result in terms of two main things. First was there was a better pickup rate of aggressive cancer. So by only biopsying the abnormal area, we actually found more significant cancer than a random biopsy of the entire prostate. And second, we found less aggressive prostate cancer, less of the insignificant prostate cancer in the patients who had an MRI scan compared to those who had a systematic biopsy. So this is great. It means we have a more accurate diagnosis of aggressive cancers, and we're not finding the silly cancers that we don't need to find. So this is a really important study. I think the precision study, published as well in the New England Journal of Medicine today, will fundamentally change the way in which we approach early detection of prostate cancer. It's going to, I think, make a difference almost immediately. I can tell you in my practice in Melbourne, where we use a lot of MRI scans already, what I'm going to take home is, instead of doing a standard biopsy, including all areas of the prostate, I will immediately decide to only biopsy the abnormal areas. And what Dr. Kazi showed in his study is that reduces the number of biopsies from 12 or 14 per patient down to only 3 or 4. And he also showed that that means less bleeding, less pain, less complications, etc. So for me in my own practice, and I'm sure for many others around the world, we're going to adopt this paradigm of MRI scan and then only biopsy the abnormal area. There is one contentious finding, of course, and that's because in this study, if the MRI scan was normal, the patient did not have a biopsy. Now, many people will find that a little bit uncomfortable to say, well, look, the patient's already got some suspicion, the PSA is a little bit raised, etc. Are we truly going to put all our faith in the MRI scan such that it's normal and then we don't do a biopsy? And as I commented in our discussion afterwards, I think that while that may be appropriate for some patients, there will certainly be a group of patients who have red flags. And even if the MRI is abnormal, we will look for example, there's a strong family history, or the PSA is accelerating, or they have a BRCA mutation. And I think there will be a subgroup of patients with a normal MRI scan who should still have a systematic biopsy.